Good evening, everyone. For those already joining the meeting, a very warm welcome. We will allow every attendee to join the meeting, and we plan to start at 6 p.m. sharp as planned. So nice to see there are people from all over the world joining us. Mexico, Luxembourg, Kazakhstan, Scotland. Good evening to every one of you. We give everyone a little bit more time to join, and we'll start at 6 p.m. sharp as planned. Okay, almost 180 participants. Welcome to our second ERC Zoom webinar. I'm pleased to host Carsten Lott this evening and Tino Greif. Tino Greif, who is Director Training and Education from ERC, and Carsten Lott, who is the Chair of the ALS Science and Education Committee. Gentlemen, very warm welcome this evening. And to our audience, thank you for joining us on a Friday evening. We will talk a little bit on how to restart ERC courses. Already did one webinar on that topic, but we received a lot of questions. So we will try to dive a little deeper into the matter and to already give you an insight of some pilot courses that were run in Austria and in Switzerland. Tino, I will start with you as our first speaker this evening. Welcome, Tino.
Hi, nice to meet you and all the participants. Today we like to answer some questions from the last time, and to start I prepared a little bit and I will share now my screen so you see this presentation, which now is on the presentation mode. I hope so. Good. The question is how to do courses, and the topic I should address is e-learning as an ERC educational strategy. That's not something new, because for a long time we have a lot of e-learning on COSI, and COSI is the virtual learning environment of the ERC. Only to explain you, for the content, the science and education committees, which are these, the science and education committees are responsible for the content, which means which text, videos, quizzes, whatever is on the virtual learning environment. For the translation into the in the local languages, the responsibility is by the National Resuscitation Councils. So all this together will transform in the future, hopefully, COSI in a more suitable virtual learning environment for all the users. Another information, COSI 2020 will issued on the 1st of October with a lot of new features, and this is in preparation to the guidelines, which will come out in 21. These guidelines are the 2020 guidelines, but they will come out at 21. And these new guidelines will trigger a little bit changes in the ERC courses 21. The biggest change I see is that COSI will be, for the future courses, the main learning resources. So we want this kind of blended learning, that we have an online training on COSI, which is all the resources people should know to go to a course and to pass a course. And then the course itself is this face-to-face training. At the same time, in 21, we really want to start the recertification. And with recertification, it means that lifelong learning in resuscitation will start. And again, for the lifelong learning, we will have e-learning modules and obviously hands-on modules with assessment. The first e-learning module we already have, also for recertification, is the COVID model, the module on COVID. So why is it not changing? Okay. So now, how are we going to integrate e-learning in our ERC courses? We already have available on whatever course you are teaching and participating a lot of material, videos. Mostly at the moment it's used as a pre-course preparation. In the future we will include much more the pre-course tests, and at the moment, it's mostly used as an addition to the course manual, or in some people using the online learning as a replacement. The first big change is really the COVID-19 module. This is the first online course, and we have a downloadable PDF. Here it's displayed where you can find it. And that's the way we like to go for the future. The future will be COSI as the main learning resources. The future manuals will be far, far smaller, So the printout manual, if you still want to have a printout, has only the material which is needed to go to a course. All the rest, all the other information will be on COSI. So we really push forward that the e-learning part is the major part, with all the videos, quizzes, detailed information. We have already modular courses, and this might be a strategy where the e-learning part could be more. An example exists, for example, from the Resuscitation Council in the UK. They have a one-day e-learning part and a one-day on-site training. And again, what we like is long life learning, and this exists about e-learning and hand-on modules. And over time, so every 4 to 6 years, we want to see if people are competent in the delivery, what they learn on the hand-on modules. Very shortly, one example how this works. We started at the University of Bern our courses for the 6-year students. And in preparation here, you see the aisle where the classrooms are on each side. The preparation of the long sleeve gowns. Each student had one, they were color coded, there were name tags. So for the entire course, they had their own personal protective equipment. They were wearing surgical masks, safety goggles, and gloves. We used gloves all the time, so this was nothing new. The really new stuff was surgical mask, glasses, and gowns, which were not used before. Major important, this is in German because this is from the course, how to protect, distance, wearing mask, hand hygiene, don't say hello by touching your hands, and you have to, if you have to sneeze or something, you do it in a proper way. Here, a short picture how this looks like. So they have their name tags here, the gown, the masks, the eye protection masks, and they were groups of 6 people, 6 students, always the scenario team, 3 persons. This was, so we did in Bern a one-day e-learning program and a one-day on-site. The e-learning program, we performed 5 webinars, 1-hour webinars with Zoom, very easy to do. And we covered all the special circumstances in 2 different webinars: peri-arrest arrhythmias, post-resuscitation care, ethical and end-of-life decisions, rhythmology, and at the end, the blood gas analysis and capnography. The instructors essentially they did choose one topic, and essentially they said on which days they have time and at which time. Individually, they had to look a podcast we taped for the general ILS algorithm and all the videos on the learning platform. The manual was to study, but we pushed them into COSI as an online learning, which was accepted by the students without really great. They liked it. And we insisted that they have to go through the COVID-19 module. So this was the first day, all together, 1 day of e-learning. What was new? We did 1 webinar beforehand with the instructors covering how to teach a webinar. So what are the technical issues, how to prepare, and how to start interaction with the audience. And in a second webinar, the day before the on-site course, we did a faculty meeting in the evening. So we reduced really the on-site part to training, which is seen here. So this was the welcome part. We started with half an hour on personal protective equipment, how to put it on, how to get it off, and all this stuff. And then a standard program as you might know, for advanced life support, BLS and defibrillation, ABCD approach. Then the ELS demo, for this we use the video from COSI in the different groups, so not all together, and in a scenario. And then scenarios, as you have 5 in a row, the breaks were not at the same time, the breaks were divided, so only the greens were with the coffee, and when they went back to their teaching room, the group blue came out, and then the yellow, and then the red group. So we tried to have as little as possible people in these social areas. Lunch break, all had to leave outside. The advantage now in summer is you can have open windows, people can go out. In the afternoon, we ended with the multiple choice test in a large lecture room, and at the same time on 2 stations cardiac arrest testing, and then final closing of the course. So the participants were here. They stayed all the time with one instructor in the same room, color-coded. So no mix of instructors, no mix of people. Feedback, they liked it. So overall, they liked the webinars, not all the topics in one block. They had more time to prepare. The field also far better prepared. It was a challenge for the instructors doing the webinars, being not so close, and it was a long day for the students and for the instructors. So we started at 8 o'clock, we started at 7:30 with the instructors. We had a short faculty meeting and sorting out the rooms, and we ended at around 7 o'clock in the evening, so it was really long, but they liked it. So only an impression how this worked. Here they are in action. We had always an instructor. They were not covered with, because they could stay away. The distance is maybe not about 2 meters, but at least it's 1.5 meters. But all of them had surgical masks. We will see afterwards how this surgical mask works. To end, you will see this again. Stay calm and start to run safe courses. I found this from a friend of mine in Canada. In some other areas, they measure the difference like this. For our courses, if people, for the participants, it's hard to stay more in a larger distance than 1.5 meters. So they are really close. You see this here, but the instructors can really stay away 2 meters easily. So that's all for the moment. And with this, we might start the discussions. I will stop this and we are back to the full screen.
Thank you, Tino, for this presentation. Just remembering to everyone that if you have a question, you can send this through the Q&A, and we will try to address it. Already have a couple of questions for you, Tino. One is regarding the recertification part that you showed us. The question is, does it apply to all European countries?
From next year on, we want that in every European country they start a recertification program, which means if you're doing one module each year, your certificate is valid again another year for another year. So we are looking at 2-year periods because we know that sometimes people cannot do it in 1 year. So in 2 years, 2 modules, and then your certificate is valid another 2 years longer. And so we are going into a lifelong learning, and your certificate is for as long as you are doing this forever. After time, which is in between 4 to 6 years, we want to have a kind of exam to see that people not only are attending recertification modules, they are really able to resuscitate people.
Okay.
I hope details will come later.
And then another question was from Francesc, who wanted to know how you did the practical assessment in this 1-day course. Was it based on continuous assessment, or did you have a formal assessment on site?
Standard assessment. So half the group were in we have there in our center a large room, so they were sitting like always very with a large distance. They were doing their MCQ, and the other half were at the exams, and this was not this. It was not a problem with distance and all this stuff. So it worked very nicely. A standard testing like all the courses. So we did not change this. The main issue I would like to transfer is whatever you are doing, you have to provide the entire content of an advanced life support course and to give all the people the same chance to practice the scenarios. That's the most important. You have, and at the end, we have to look, are people able to do it? We had even 3 retests, and one girl will come back on next Monday for doing her 3rd attempt to pass the practical test. Theoretically, they had a high number, but we were surprised how poor the performance was. But this happens in some courses, nothing unusual.
How do you, when the faculty stays always with the same candidates, how did they evaluate for instructor potentials during that course?
We had one instructor fixed in one room, and then I, as a course director, and another very experienced, so it was the co-course director. We were rotating, looking at the people, and we discussed then in the breaks, is this something for an instructor potential? And because it's hard to be an entire day, so we jumped in and gave them a little break. So I did some scenarios with the group, and then the instructor could go out drinking a coffee or having, I don't know what they were doing because I was teaching. So if you're going for this format, I really would recommend to have a little larger faculty to enable this possibility of having people out, instructors, not because it's really hard to teach 10 hours in a row.
Okay, we understand that the time is clearly limited. People are asking through the Q&A that for the airway management, for example, you need candidates to prove that they can practice the skills. How did you tackle that within that one-day course?
So we used our e-learning program for airway management. In this specific situation with the students, they had to do an anesthesia rotation, all of them. And for this type of course, we skipped this part because we knew we were teaching them beforehand airway management. So we said, okay, this is not possible, so and they can do it. All of these students had to do an immediate life support course last year, and last year they had an airway station. So we were pretty sure they know what they were doing. And during the scenarios, we looked at it. And airway management was not a real problem. So they did 2-hand face masks. So they got the idea of the COVID module, how to do face mask, putting in a laryngeal mask. And intubation was really never done.
No problem, but how would you suggest to do it for groups that are not that experienced with airway management or maybe need some refresher?
Then you have to decide which part, then maybe you have to skip one scenario. If you really need an hour or half an hour on airway management.
Okay. We have a number of other questions, but maybe it's interesting to look at another experience, and I'm referring to Carsten's experience in Germany. Might be answering some of the questions we receive, and then we can move further on with the discussion. Hi, Carsten. Good evening.
Yeah. Hi. Good evening, everybody, and thanks for having me back to that webinar. Warm welcome to everybody out in the world joining us, to all our friends and everybody interested in the ERC work. So I would start with a presentation as well. So my task was to get you an idea how to prepare for the courses. So this is kind of continuing what Tino just said. I'm going to share my screen. Wait, let's wait a moment, and here we are. Yeah. So it's about preparation for the courses. I would like to start with the ERC safety statement that is part of our guidelines. And I think this accounts for our educational programs as well as for management of the real patients. So if we teach mainly healthcare professionals at the moment, and it is not acceptable to compromise the safety of these healthcare professionals by a training program. So for our educational programs, we have the same priorities as we have in real life. Priorities are we need to take care of ourselves and of our colleagues and bystanders. Fortunately, we do not have to deal with patients when we're talking about educational programs. If we look at the infection risk we have throughout our courses, there are, I think, two major issues we need to take into account. Yeah? One that might easily be known and managed is the infected candidate or an infected faculty member. But what we know pretty well from the COVID parts we experienced throughout the past few months is that we have a number of asymptomatic carriers of the virus that we will not be able to identify. In Germany, we have been lucky as far. We do not have that big numbers of infected people, so it's low risk running courses. And so we did not have to pause our courses for a long time. I think I had to cancel my course center 1 or 2 courses, but I restarted our courses already in May. And in the meantime, I did 2 advanced life support and 5 immediate life support courses. And this is all the experience I want to lead you through within the next few minutes. First of all, it's important to prepare for your courses. You need to have a proper preparation, and that includes very strict briefing of your faculty and of your candidates. They all need to know about things they need to take care for before and throughout the courses. So we kind of established an extra information for faculty and candidates we are sending around before starting our courses. Then we developed a checklist. The checklist is kind of used in the 2 to 3 days before the course to make everybody aware of the problems that might arise when coming to the course. And we want to know from everybody, candidates and faculty, if they had contact with COVID patients. But we added the contact without personal protective equipment because many of us have contact to COVID patients, but we are safe because we have our protective equipment with us when we manage the patients. Then we need to know if there has been contact to risk areas and if there have been signs of a COVID infection. And additionally, we store the contact data of our candidates and the faculty in case there is an infection in place. Then we checked the kind of protective equipment we need to use throughout the courses. So on one hand, I think it's adequate to practice in the full protective equipment to simulate the management of a COVID patient. So this is why we keep it in place. But on the other hand, we try to find out what kind of infection risk we have throughout the resuscitation training. What you need to bear in mind is that if you do resuscitation training, you need to practice chest compressions. And doing chest compressions is work for the candidate who's doing that. And this increases the breathing work that candidate needs to do. And this increases the rate of airborne particles that is coming from that candidate. And this is what we wanted to check. And I have a small video on that to give you an idea how that airborne particles are spread in the room during the training and how you can protect yourself from that. So first part of the slide is training without protection. Smoke is simulating the airborne particles, and you can clearly see that the airborne particles are spread all about the practice place. Now we use the standard surgical masks. This is what is recommended. You can see the amount of airborne particles is somewhat minimized in getting the back of the candidate practicing, but it's not really effective. So adding face shields to that. So this is getting much better. Now the airborne particles are not getting all around the place, and if the one doing chest compressions is infected, the risk is going down. And finally, we installed fans around the training scene, and now it's done. So this is what we recommend to do, and this is what we discussed with our hygiene department in our hospital to allow us to restart the courses using that full setting in the room. So to get that in detail, we need filtering face pieces. They should be at least FFP1 or higher. I think in the overall setting for training setting, FFP1 should be sufficient. You need some kind of eye and face protection. And from what we've seen in the video, a full face shield might be more effective than only wearing glasses or goggles. You need your long sleeve gowns. For training purposes, we did not use the waterproof ones because these are needed as resource in the hospital. We used other gowns for training purposes, and as Tino already indicated, gloves should be used all the time over your training program. What you should not forget, and this is an essential part of the trainings we did in advanced life support as well as in immediate life support, you need to talk about the doffing of your protective equipment to avoid the self-contamination in the end, because this is something where most of our candidates are not used to. So you need to give them a practice on that, and you need to give them a clear picture on the adequate way of disinfection they need to do on one hand, and on the other hand, disinfection stands for cleaning the mannequins and cleaning all the equipment you have following every single scenario. And this is what we learned. I did not really think that this would be that effective, but it's really impressive if you use it in courses. If you use fans, you are really able to remove the air and to mix the air within the room within a short time to get rid of that airborne particles. When teaching, and this is what we need to take into account in preparation for courses as well, we should take care that we do not teach chest compressions or airway interventions without the airborne precaution protective equipment. We changed the number of staff, so also the number of candidates within the training program when doing resus training to a maximum of 3, one doing the ventilation part, one doing the chest compression, and one doing additional things or exchanging with one of the others. And we allocated the position of a gatekeeper that's taking care for the number of candidates that are practicing at the same time. And we're placing oxygen masks until the bag arrives. We use viral filters all the time for our trainings. We try to minimize the time for manual ventilation using the 2-person technique, and we go for airway management as soon as possible, as early as possible, and recommend the use of video laryngoscopes. This is how we set up our rooms. You can see the fans, the open windows. You can see the colored tapes that are marking the distances. So we mark distances between the places where the candidates are placed. So this is 1.5 meters each. And we mark the distance from the mannequin. This is 1.5 meters in radius as well. And within that radius, we only allow maximum of 3 people to stay during our course. We have fans placed at the doors and at the windows to be able to ventilate the air in the room as fast as possible. This is the equipment, the protective equipment we use. I've already been talking about that. And we also did a survey. So this is the number of candidates we taught during the pandemic is going on for the moment. So we had 34 ALS candidates, and we had 90 immediate life support candidates as far. And they told us that they feel that hands-on training pretty important during the pandemic. They felt that training using the protective equipment is very helpful. They experienced that using that protective equipment makes our hands-on trainings much more difficult, but they told us that they felt that the infection risk was pretty low and that they felt safe during the course. And I think this is a very important message. And they felt the protective measures we have been taking during the course have been sufficient and not overboarding. Yeah, and Tino, we did not talk about that beforehand, but I have the same slide to close my presentation. So stay calm and run safe courses.
Thank you very much, Carsten. A lot of questions. I receive a lot of questions regarding to PPE and ventilation. Just want to remind to everyone that we will dedicate another topic at 8 o'clock about ventilation and PPE. So a number of things will be addressed later on this evening. But Philip had already a first question, and Tino, what you would like to comment on that regarding the gowns were the new same scenario training.
So there's a question, what does it make sense to have this thin one? We assume that our participants are not sick and they are not spreading COVID. For this reason, they are wearing a mask and all the stuff Carsten explained. The thin material is only for training purpose. So use the most cheap one you can get, or if the hospital has something which is sorted out, this is only for training purpose. And one person was asking, should they take it off? Of course they should take it off, because you have to train with them how to put it on, how to take it off as often as possible. And when a group with a COVID case, so the case is then a COVID case, you are resuscitating finished, they have to take it off. And the other 3 or 2 persons in the room are observing how they are doing this, and they give feedback on the procedure. So that's one point which was in the question. And the other one, we also opened the windows to have nice circulation, and it's clear now it's summer. The question what to do in winter, I can only say I have no clue now, but we will see how it worked, if we can open the windows. And if you are in an area where all this is not possible, then I have to say, then you can't do safe courses with COVID, but you can at least have an intention to do so.
Okay, thank you, Tino. We were talking a lot about advanced courses. A number of questions raised about basic life support courses, which is even more important, because how do you train lay people in the use of PPE? They might not always have them with them in a bystander CPR situation. How would you address the BLS training situation? Maybe
Carsten.
both of you.
Yeah, so this is a difficult one for the time being. So I think for the time being, we need to tell them that they take a risk of infection if they start chest compressions in somebody that has a cardiac arrest. So in real life, we try to staff all that lay people that potentially will start the resuscitation with protective equipment. So this is what we should recommend. They should have protective equipment available. They should don that protective equipment before they start chest compressions.
Okay. And in case they don't have the protective equipment, because a surgical mask or a tissue mask, a cloth mask, sometimes people are wearing them. More countries make it, mandatory in some circumstances. But if you don't have it with you, does that mean as a bystander that, you don't do anything? Because I came across an article which was an interview with a large training organization member in Belgium, and they stated that if a bystander doesn't have a surgical mask or gloves, he is not allowed to touch the victim. So that means that people will not receive early CPR and might die by doing nothing and keeping social distance. So that has a lot of impact. Anyone who wants to comment on that?
Yeah, it has. So if you look at our guidelines that we just recently published, then we recommend to cover the head and then to start for chest compressions. This is the recommendation for lay people, and this is the kind of training you can offer for lay people. Won't be discussing an approach like that for our school children education as well, to go for chest compression only with covered head to kind of avoid to become infected by airborne particles if the one in cardiac arrest is COVID infected.
Okay, and another question, during the training, do you teach the standard algorithms together with the COVID algorithms, or do you limit to the COVID algorithms for now? How do you do that?
In our courses, we mixed it. In our courses, we mixed it. We had COVID scenarios, and then they had to apply the COVID system. And the next scenario was a scenario without COVID, and a normal patient, and then he was free. So this is depending on the group and on the experience and how good they integrate this.
So we made it totally clear that we are talking about both situations. So we had some specifics concerning the COVID patients. So for example, in our special circumstances sessions, we add one scenario for patients in prone position to get them an idea how they can manage a patient in an ICU setting in prone position and how they can provide resuscitation for that guy. But on the other hand, I feel it's important that they do all the practice training in the full protective equipment. So there will always be a touch of COVID in your training programs.
Okay, so in summary, I understand that for training you advise to wear PPE, long sleeve gown, surgical mask, and a face shield, if possible to fan or ventilate the room. Of course, we already talked about it last time, no pocket mask or no face shields, given the risk of transmission. So in professional rescuers, it's easy to learn them work with a back valve mask, 1 or 2 persons technique. But how about lay people? Because there was a lot of discussion as well recently that not every lay people, and with lay, it can be a person with a duty to respond, like bay watchers or at the beach. They are not trained, or in some circumstances, they are not allowed to use a back valve mask. So how do you see those situations?
So this depends on the setting where the resus take place. So if you talk from a real life resuscitation, then I think you need to clearly differentiate if this is in your family setting or if this is in a setting that is far away from your family or from people you know. Yeah, I think in a family setting you're not that reluctant to provide mouth-to-mouth ventilation as you used to do before. But if it's a foreigner, then I think people will be much more reluctant to do so. And for training programs, I would clearly recommend, if they are not able to use professional, things like bags and like pocket masks or things like that, that have a viral filter included, then it should be compression only for the moment.
Okay, that's.
I can support only. A lot of questions come up. What is possible? You have to use your daily brain. Whatever is possible, you are going to do. If you don't have masks, you can't use it. But if you have one, you use it. And we might have to think also for lay people and all basic life support. Maybe we should start to teach back mask ventilation. Even it's hard to learn, but from the equipment side, with an AED, a mask and a bag can be delivered in the same package. This is not a problem. And this is to look at it. At the moment, it's really hard because a lot of people suffer now because they are not coming to the hospitals, they are not in the emergency room, and more people die because they do not get the attention of basic life support because people are in fear of getting infected. And we have to say, most happens in their homes. So families, they are living with these victims, so they can even do mouth-to-mouth ventilation because they are living close. We have to transport this message that we can save lives while we are doing this, and use whatever you have to protect transmission of virus. So you can cover the mouth, the face of the victim with whatever is there. If you feel safe, if you say, I can do this. This is not a change to the area before COVID, because in the area before COVID, it was the same. If you don't think this is the person is I don't know what's going on, drug addicted, infection, whatever, then you did chest compression only. So there's virtually no change.
Okay. With regard to training, a question that already was raised during the last webinar, some organizations or institutions are, instead of retraining every year with a crisis situation, are moving the requirements from 12 months to 18, 24 months. We know that regular training is important. Sometimes it's difficult with the current crisis to maintain to that, but what would you advise to do given the current circumstances?
The advice is still every year training, because we know from a lot of studies that even a training every year is not enough to stay competent if you don't use the skills on an everyday base. And I fear if we start to say, okay, 2 years is enough, then the entire system breaks down, and then people start, I know this from the hospital, and they say, why do we have to do this every second year? Can't we do this every 3 years? So at the moment, we are happy if courses start again. And if you say, I'm able to do a training for my staff every year, great, do it, go for it.
Yeah, and additionally, and this is the experience we had from our training programs, candidates told us that they feel it is even more important to run training programs now because the conditions have changed. So if you look at the human factors part we have in our courses, especially the communication, this has changed. If you use your protective equipment, the communication, the non-verbal stuff is different. You need to be much more focused, much more directed. And this is what you need to train. You need to train the different strategies you have to use for COVID patients and all that stuff. And this is why it's really important right now to restart, to keep on going with the training programs, and to better go for to minimize the exposure time for shorter programs with a higher frequency. And this is what was recommended already in the 2015 guidelines.
Okay. Thank you. Thank you both. I think we addressed a lot of questions. A lot of this information is already on our website. We have a document on Pathway to Restart courses which can be downloaded online. We have a free accessible cozy e-learning on COVID-19, tackling a lot of the chapters we discussed. Of course, as the situation and the evidence is currently evolving almost daily, we will need to adapt a number of strategies along our pathway to resume those courses. And especially with regard to ventilation and PPE, we will have another webinar at 8 o'clock European time this evening. I've asked the office to put the registration link online. For those of you who are not registered yet, you can still register to that webinar. It will be streamed live on Facebook as well. And we are recording those meetings, so for those who were not able to attend the meeting, they will be able to watch it on a later time as well. Any one of you who wants to give well, both of you, I would like to ask you to give a take-home message for our audience. And I will start with you, Tino.
My take-home message is, think what is possible in your center, start courses, start with a small course, maybe only 12 people and 5 instructors, and get experience. If you're using e-learnings, we did it for the first time. It was surprisingly easy and well received. So try things out. For me, it would be important, report back. So we can use your good experience. There was a question, is there a video about this and this? I said, no, but make a video, send it in. And if it's a good video, we distribute it. Your name will be on the front page. And then we have the next video for teaching. The ERC, we are all the ERC. We have to work together. We have to do all this stuff, translations, videos. If it's not coming from your side, who is going to do it? This is a volunteer organization. And we all have to do it. So start courses for yourself. Think you might be a victim of cardiac arrest in your area. And then you want that all the people around you will help to survive. And therefore you have to train more people.
Thank you, Tino. Carsten.
Yeah, I can only add to that. In a situation like we experience it with the pandemic at the moment, we need to adapt to the changing variables. So it took us some time to get a clear picture of what's happening to us at the moment. But now, and this is where I fully agree and fully need to support what Tino has said, we're getting a phase where people start dying from cardiac arrest because we are running out of training, we're running out of experience, we're running out of skills, we're running out of competence. And this is where our courses are really necessary for. I receive a lot of requests from all over the world, either on restarting courses or even on starting courses in new settings, in new countries, in new places. And I can fully support that. And you need to do that on an individual basis. So everybody needs to check for his own regional setting, for the own regional rules that have been set through the pandemic, what is necessary, and try to establish as many courses as possible to kind of guarantee survival of the patients in cardiac arrest.
Okay, thank you very much, both of you, for your time. My take-home message would be that well, there are already a lot of useful guidelines. The most important one, as I understood from both of you, is to use your common sense to keep it safe. But with a lot of common sense and safety, we can still manage to save a number of lives. So the office is currently posting the link to our next webinar, where we will dive deeper into ventilation, into evidence from randomized controlled trials regarding airway and COVID-19. We'll talk about video laryngoscopy and about transmission, aerosol transmission of the virus, and the evidence we have up till now. So a number of more interesting topics. If everything's going right, the link should appear on the screen, or at least I've asked to post the link in the group discussion for those who would like to join us later on this evening. Thank you very much, everyone, for attending our webinar, and hope to see you soon again. Stay safe. Bye.
Bye.
Yeah, goodbye. Thanks.
Okay, for those waiting for the link, I would like to ask you a couple of more seconds of patience. It's right away. We will post it in the Q&A right away. Just sorry for this delay.
There's a question about the videos Carsten showed. We have to ask him if it's possible that he can share it on the web page. This might be part of an investigation, and so maybe they are writing up an article and having these videos, and then it's freely available. We can't answer this at the moment.
Okay, we are clearly experiencing a technical problem to post it in the chat, but if you go and have a look on our Facebook page, you will find the link through the next Zoom meeting, and you can still register. And in the meanwhile, it has appeared on screen as well. You just have to write it over, and you'll be able to join us later on this evening. Thank you for your time and patience, and see you later on. Bye.